Hello everybody, so thank you for joining me today, and in today's video we're going to be looking at pleuritic chest pain for finals. So the Medicine Guide aims to support medical students throughout their entire journey at medical school, so I've made videos on how to be successful during medical school, like how to be successful during the pre-clinical years, how to be successful during the clinical years, how to get the most out of GP placements, how to get the most out of hospital placements, how to succeed in clinical OSCEs. And I've got a paediatrics edition, so focusing on the high yield topics that crop up in medical school final exams, such as a child with a mass, a vomiting child, congenital heart disease, rashes for finals, limping child for finals, and genetic conditions for finals. Also, I've got an obs and gynae condition, focusing on the high yield range of topics that crop up in exams, such as chronic abdominal pain, gynecological cancers, acute abdomen for finals, obstetric emergencies, high yield STIs, and this video is part of the Cardiology edition, so atrial fibrillation for finals, pleuritic chest pain for finals, infective endocarditis, aortic coarctation, and high yield electrolyte disturbances with ECGs for finals. So let's get started. So typically pleuritic chest pain describes a unilateral sharp chest pain. This chest pain is aggravated by deep breathing, so inspiration. It's also aggravated by coughing, sneezing and laughing. And usually pleuritic chest pain is relieved or improved by taking shallow breaths, and pleuritic chest pain can be referred to the neck and the shoulder. Now, the causes of pleuritic chest pain are very high yield and crop up time and time again for medical school final exams, and the causes of pleuritic chest pain usually begin with the letter P, so that helps to simplify things. So causes of pleuritic chest pain which are very high yield for medical school final exams involves pericarditis, pleural effusion, a pneumothorax, pulmonary embolism or PE, and finally pneumonia. So let's get started and we'll talk about this in a little bit more detail as we go along. So let's start with pericarditis. So the underlying key pathology for pericarditis is inflammation of the pericardium. Now, the pericardium consists of the parietal pericardium, which is the most superficial, and the visceral pericardium, which is the most deep. So the visceral pericardium is the layer of the pericardium that's in closest contact with the heart. Now, the parietal pericardium and the visceral pericardium creates this pericardial sac, and this pericardial sac is lined by pericardial fluid. So if you have a look at the picture in the far right hand corner, hopefully you'll begin to appreciate this. Now, pericarditis is due to inflammation of the pericardium. Now, you need to be aware of the risk factors for pericarditis, because this is something that's quite important and is quite high yield for final exams. So the mnemonic that I used in medical school and thought was quite useful was cardiac rind, so we'll go through this. So collagen vascular disease such as SLE, rheumatoid arthritis and scleroderma are all pro-inflammatory conditions. So any degree of inflammation of the pericardium, particularly with collagen vascular disease, is a risk factor for developing pericarditis. Aortic aneurysm is a risk factor for developing pericarditis, as is radiation therapy, and drugs such as hydralazine and anti-epileptic drugs, infections such as Staph aureus and Coxsackie virus, acute renal failure because the elevated levels of urea will irritate the pericardium, leading to a uremic pericarditis, and cardiac infarction. Now, something to bear in mind is that Dressler syndrome will typically develop 2 to 6 weeks following an MI or cardiac operation. So these patients will complain of fever, pericarditis and pleurisy. So that's something that's quite high yield and something to keep in mind. Other causes of pericarditis involve rheumatic fever, injury, Dressler syndrome, so we've already spoken about that. So now we're going to focus on the signs and symptoms and the complications of pericarditis. So pericarditis, it begins with the letter P, so it presents with pleuritic chest pain. So this is a chest pain that's localized to either the right side of the chest or the left side of the chest. And the pleuritic chest pain is worse when the patient is lying down. And this particular type of condition has a pleuritic chest pain which is improved by sitting forwards or leaning forwards. there will be a pericardial friction rub, and the Kussmaul sign is a classic sign that presents itself during medical school final exams and is associated with pericarditis. So Kussmaul sign is when the patient will have a raised JVP during inspiration. Patients will also present with fever. Now, a complication of pericarditis involves chronic pericarditis. So if the acute pericarditis persists for many weeks, then it leads to a chronic pericarditis, a pleural effusion. It can lead to a pericardial effusion, and then that would lead to cardiac tamponade. So this presents with reduced breath sounds, shortness of breath, and hypotension, as well as lightheadedness. So let's begin by looking at the investigations needed in patients presenting with pericarditis. So we need to perform an ECG. Now, an ECG with pericarditis will classically present with saddle-shaped ST elevation or concave ST elevation. Now, the most specific finding of pericarditis on an ECG is PR depression, and let's look at examples of this. So if we begin with looking at the far right-hand corner, we can see saddle-shaped or concave ST elevation. Now, this refers to ST elevation across multiple leads on the ECG, which are not related to one another. So you can see that we've got ST elevation present on leads 1, leads 2, a little bit in AVL, AVF, slightly in V1, but definitely in V2, V3, V4, V5 and V6. So you can see that there are multiple leads involved and they all have ST elevation. So that's your classic finding of saddle-shaped ST elevation or concave ST elevation in pericarditis. But the most specific finding of pericarditis is PR depression, and you need to be aware of this because it can come up as an SBA. So the most specific finding of pericarditis on an ECG is PR depression. So if you have a look at the ECG below, at the bottom, you can see an example of pericarditis, which I've encircled with the blue circle. So that little dip between the Q wave just before it gets to the R wave, that little dip is known as PR depression, and that's the most specific finding of pericarditis. Now, a complication of pericarditis is a pericardial effusion. Now, a pericardial effusion on an ECG will present with a low voltage QRS complex or electrical alternance. So if we begin by looking at the ECG on the far left, we can see an example of low voltage QRS. So the peak or the amplitude of the R wave in that QRS complex is very low. So that's why it's called a low voltage QRS. Now, if we look at the ECG below that, where it shows an example of electrical alternance, we can see that the amplitude or the peak of that R wave fluctuates with each QRS complex, and that's an example of electrical alternance. Okay? So now we're going to focus upon further tests. So we need to do a chest X-ray in pericarditis. So pericardial effusion, like I previously mentioned, is a complication of pericarditis. Now, the key classic sign on a chest X-ray of pericardial effusion is what's known as a water bottle sign. So I'll just give you a short while to appreciate that on the chest X-ray on the far right hand side. Now, another complication of pericarditis is pleural effusion. Now, pleural effusion is something that I'll discuss later on in this video, but just so you're aware, on a chest X-ray it presents with this meniscus sign, and it presents with a loss of the costophrenic angle. So if you have a look on the chest X-ray, you can see almost like this U-shaped bend. Now, that U-shaped bend, that curve, is what's known as the meniscus sign, and also there's a loss of the costophrenic angle as well. Now, a transthoracic echocardiogram is needed to confirm the diagnosis of pericarditis. So in acute pericarditis, the transthoracic echocardiogram will appear normal, but in chronic pericarditis, there will be a stiff, serous pericardium because the movement of the heart, so that contraction and relaxation action, has been restricted because of the stiff, serous pericardium because of the persisting inflammation. Now, in terms of management, We initially offer patients naproxen, which is an NSAID, and we give them colchicine. Now, if the NSAID, so the naproxen, and the colchicine are ineffective, or if it's contraindicated, then we give patients corticosteroids. Okay? So now let's look at pleural effusion, which also presents with pleuritic chest pain. So there are two types of pleural effusions. We have a transudate pleural effusion, where the protein count is less than 25 grams per litre, or we have an exudative pleural effusion, where we've got extra protein, so the protein count is more than 35 grams per litre. And also we have a chylothorax and also an empyema. Now, typically in exams, pleural effusions and transudative pleural effusions are the most high yield. I've included chylothorax and empyema for completion, but I would say definitely make sure that you remember examples of transudative and exudative pleural effusions, because that's a very easy SBA that they can throw in exams. So heart failure is the most common cause of a transudative pleural effusion. Other causes involve nephrotic syndrome, liver failure, hypothyroidism, and Meigs syndrome. So Meigs syndrome is an ovarian tumour which leads to right-sided pleural effusion, and I've underlined that in blue because Meigs syndrome is something that can crop up as part of obs and gynae, and it can also crop up as part of respiratory medicine, and because pleural effusion is a respiratory condition, and it can also crop up under cardiology because a pleural effusion is an example of pleuritic chest pain. So just be aware of Meigs syndrome. And also constrictive pericarditis is another cause of transudative pleural effusion. Other examples of exudative pleural effusions involves pneumonia, which is the most common, TB, rheumatoid arthritis, SLE, lung cancer, mesotheliomas, pancreatitis, PE sarcoidosis, yellow nail syndrome, which presents with a triad of yellow nails, pleural effusion and lymphedema. Now, chylothorax is due to a ruptured or obstructed thoracic duct, so it might be from surgical trauma or a mediastinal tumour which is causing lymph to accumulate in the pleural space. So an empyema is when pus collects in the pleural cavity and is infected by anaerobes. It could be a complication from thoracic surgery or a ruptured lung abscess. A perforated esophagus, mediastinitis, so that's inflammation of the mediastinum. Now let's focus on the signs and symptoms of pleural effusion. So like I said, patients can present with pleuritic chest pain, and this is then referred to the shoulder or even the abdomen. Now the key classic feature of pleural effusion, which you might be able to elicit as part of your OSCEs, but will definitely be found in the SBA, is that pleural effusion presents with a stony dullness on percussion, and that's something that you need to know because it's a very classic high yield SBA. Patients also present with bronchial breathing, reduced breath sounds, reduced tactile vocal fremetus, so that's fewer vibrations on the chest wall when the patient is speaking. Now the LIGHTS criteria is something that's very high yield, and it crops up time and time again for exams. So the LIGHTS criteria is performed for pleural effusions where the protein count lies between the range of 25 grams to 35 grams, so it's in between that transudative pleural effusion or an exudative pleural effusion. So just to clarify, a LIGHTS criteria is performed in those situations. Now the whole point of performing the LIGHTS criteria is to diagnose whether the pleural effusion that's considered in between a transudative and exudative is definitively an exudative effusion if it has the following features. So if your pleural fluid protein count to serum protein counts, that ratio is more than 0.5. If your pleural fluid LDH to serum LDH is greater than 0.6, or if your pleural fluid LDH is more than two-thirds the upper limit of normal for the serum LDH. Okay? So now let's look at some of the tests that are needed in pleural effusion. So like I mentioned in the previous slides, we need to perform a chest x-ray in patients who have a pleural effusion. So this classically presents with a meniscus sign, so it's that U-shaped bend during a chest x-ray. It shows that U-shaped bend with shadowing, and there'll also be a loss of the costophrenic angle. Now we need to do an ultrasound guided pleural aspiration to confirm that it's a pleural effusion, because on the chest x-ray all we can see is this degree of shadowing. We're not sure if that shadowing is due to infection, it could be due to a mass, we're not really sure. So that's why we need to perform a pleural aspiration. So if the aspirate is a clear aspirate, it's more likely to be a transudative effusion. If the aspirate is cloudy in its appearance, it's more likely to be an exudative effusion because of the extra protein content causing this cloudy appearance. At least that's how I like to remember it. Or you can have a milky aspirate, and that's because of an underlying chylothorax. Now, in terms of managing these patients need to have therapeutic aspirations. After that, they can receive an intercostal chest drain. Now, if the chest drain is unsuccessful, or despite the chest drain the pleural effusion is still persisting, then the last line of management would be to perform a pleurectomy. Okay? So now let's look at a pneumothorax, and in particular we're going to be looking at a simple pneumothorax. So a simple pneumothorax is where air enters the pleural cavity during inspiration and the air will exit the pleural cavity during expiration. And if you have a look at the diagram on the far right hand side, hopefully you can appreciate that. Now, the different types of a simple pneumothorax involves a primary spontaneous pneumothorax and a secondary spontaneous pneumothorax. So a primary spontaneous pneumothorax occurs most commonly in tall, thin young males, so they won't have any underlying congenital conditions, they won't have any underlying cardiac conditions, they won't have any underlying respiratory conditions. Unfortunately, these tall, thin young men are prone to suffering from a spontaneous primary pneumothorax. Now, a secondary spontaneous pneumothorax is found in patients who do have underlying conditions such as COPD, because the emphysematous bullae may rupture and lead to a pneumothorax. Patients who have TB, pneumonia, sarcoidosis, Marfan syndrome and cystic fibrosis are all at risk of developing a pneumothorax. So in terms of signs and symptoms, patients will have this sudden unilateral stabbing pleuritic chest pain. This pain can radiate to the shoulders. As the pneumothorax increases in size, the patient will have increasing shortness of breath. There is a sudden deterioration in the patient's existing lung conditions, so potentially these patients have COPD and there's a sudden deterioration in their shortness of breath. Now, two key signs of pneumothorax which can present in SBAs involves the Hammond sign and subcutaneous emphysema. So Hammond sign is this crunching sound heard with each heartbeat, and that's usually picked up during auscultation. And subcutaneous emphysema is when bubbles and crackles are present under the skin of the patient's neck and on their torso. Okay? Now, it's really important that you're comfortable with the investigations needed for a pneumothorax. So a chest x-ray is diagnostic in a pneumothorax because it presents with a flattened diaphragm and a collapsed lung. So if you have a look on the chest x-ray on the far right, you can see that on the patient's left-hand side of the chest, the left-hand side of the patient's chest appears more blacker, and because it appears blacker, more darker, that signifies that there's more air present in the chest. That's the side affected by the pneumothorax. You can also see that the left diaphragm appears flattened, and you can see what almost appears like this white outline quite close to the heart, and that white outline is the lung being compressed upon, and essentially that lung is the collapsed lung. So just to clarify, the chest x-ray on the far side of the slide shows a simple pneumothorax. It shows a pneumothorax affecting the left side of the chest because we've got collapse of the left lung, and we've also got a flattened diaphragm affecting the left crew of the diaphragm. Okay? So after performing a chest x-ray, healthcare professionals need to perform a CT chest which confirms that the patient has a pneumothorax. So if you have a look at this CT shows evidence of a right pneumothorax because you've got that black area on the right side of the patient's chest, and you can also see the border of the collapsed lung. So the CT shows a right-sided simple pneumothorax. Okay? We would also need to perform an ABG and an ECG in these patients. Now the ECG in these patients would just be to exclude for any cardiac causes of chest pain. Now the management of a pneumothorax is something that's high yield and crops up time and time again in medical school final exams. So if they've got a primary pneumothorax, which is less than 2 centimetres, we need to discharge the patients and review them in outpatients 2 to 4 weeks later. If the pneumothorax is more than 2 centimetres and or the patient is short of breath, we aspirate it. If the pneumothorax is more than 2 centimetres or the aspiration has failed or the patient still remains short of breath, we need to insert a chest drain. Now if the patient has a secondary pneumothorax, this is a pneumothorax in a patient who has an underlying respiratory condition like COPD, Marfan syndrome, cystic fibrosis. If it's less than 1 centimetre, we need to admit these patients for high flow oxygen and observe for 24 hours. If it's between 1 to 2 centimetres, we aspirate. If the pneumothorax is more than 2 centimetres and or the patient is short of breath and this patient is age 50 years old, or if aspiration has failed, we need to insert a chest drain in a secondary pneumothorax. So now let's focus on attention pneumothorax. Now attention pneumothorax is a medical emergency. It's something that comes up classically in exams and you have to be aware of it. So in attention pneumothorax, air will enter during inspiration, however the air can't exit during inspiration. So you've got this trapped seal of air and this air continues to enter, however it can't exit. So all of this air that keeps entering in will compress the lung and eventually it will cause the lung to compress the other structures such as the mediastinum, so it leads to this contralateral shift of the mediastinum and of the trachea. So attention pneumothorax is a medical emergency and it can arise from a stab wound or a rib fracture or even central venous cannulation. It presents with signs where the trachea and the mediastinum are deviated contralaterally, as I mentioned previously. The intercostal spaces are widened ipsilaterally, so that's on the same side as where the tension pneumothorax is occurring. There will be ipsilateral hyperresonance upon percussion, reduced or absent breath sounds ipsilaterally, and ipsilaterally reduced chest expansion. So all of the signs are occurring ipsilaterally except for the fact that the trachea and the mediastinum will be deviated contralaterally. So the management for these patients is that we need to perform immediate needle decompression into the second anterior intercostal space of the midclavicular line, and this hissing of escaping air will confirm that the patient is suffering from a tension pneumothorax. Afterwards we need to perform a chest drain and attach an underwater seal, and then we can perform investigations, because the first important thing is that we need to manage the patient because it's a life-threatening condition, and then we can do investigations later on to confirm our diagnosis. So a chest x-ray in attention pneumothorax will present with a depressed hemidiaphragm, a collapsed lung, similar to a simple pneumothorax, but the key feature is that the mediastinum and the trachea will be deviated contralaterally. So if you have a look on the chest x-ray, we can see that there's a tension pneumothorax affecting the left side of the chest. So the left crew of the diaphragm is flattened, the left lung is collapsed, but the mediastinum and the trachea has been deviated towards the right. Now if we have a look at the CT scan, the CT scan shows evidence of a right-sided tension pneumothorax. So again, the right side of the chest appears very black, there's lots of air there, and we can see that the mediastinum has been pushed contralaterally to the left side of the chest. So you can see that the heart and you can see the aorta has been pushed over towards the left side of the chest. And that will help you to identify that this patient is a tension pneumothorax, but actually you should have performed the needle aspiration. So a tension pneumothorax shouldn't be picked up during a chest x-ray. You should have been able to identify that during a clinical examination. So now let's look at a PE. So the risk factors for PE are essentially found in Virchow's triad. So you need to have a hypercoagulable state, some degree of circulatory stasis, and vascular wall injury. Now the key risk factors that crop up time and time again in exams have been highlighted by this red box, so please just have a look at that. Now, the signs and symptoms of PE involves pleuritic chest pain. The patient will have a sudden shortness of breath, they'll complain of hemoptysis, they'll have a unilateral edematous calf because PE can present alongside with a DVT, so the source of that emboli leading to the PE will be due to the patient's DVT, so that's why you need to check for a unilateral edematous calf. And also the patients will have a pleural rub, and that's the high yield phrase that comes up time and time again during medical school final exams. So now let's look at the tests that are needed to investigate for PEs. So for a PE you have to perform the Wells score, so if your Wells score is greater than 4 then a PE is considered likely, but if your Wells score has a value equal to 4 or less than 4 points, then a PE is considered unlikely. Now, a key feature to remember for all of your exams is that a CTPA is considered the gold standard for investigation of a PE. So if your Wells score is greater than 4, you need to do a CTPA immediately, but if there's any sort of delay, then offer the patient a Pixaban or a Rivaroxaban. Now, if your CTPA is suggestive of a PE, then continue with a Pixaban or a Rivaroxaban. If your CTPA excludes a PE, then consider an alternative diagnosis. But if your CTPA is ambiguous and you're not sure whether or not the patient is suffering from a PE, then you need to perform a VQ scan. But if your Wells score is equal to less than 4, you need to perform a D-dimer test within 4 hours. Now, if the D-dimer test has been delayed, you need to offer the patient a Pixaban or a Rivaroxaban. Now, if the D-dimer test is suggestive of a PE, then you need to perform immediately a CTPA, and similarly, if the CTPA has been delayed, then offer the patient a Pixaban or a Rivaroxaban whilst you're waiting. If the D-dimer test is negative, then it's unlikely to be PE and consider an alternative diagnosis. Now, other tests to be aware of when you're investigating for PE is that on an ABG it presents with type 1 respiratory failure, and on an ECG we have signs of a sinus tachycardia, the S1Q3T3 sign, right bundle branch block, and right axis deviation. A chest X-ray is performed in PE and it will present as a normal chest X-ray. So the whole point of performing a chest X-ray in these patients is to exclude for respiratory causes of chest pain. So if you have a normal chest X-ray, then that's something that occurs quite commonly in a PE. So if you've got a normal chest X-ray and the patient's complaining of increasing shortness of breath, then PE will be on top of your list of differentials. Now, another thing to consider is that if your patient has an allergy to contrast media or has some sort of renal impairment, so such as an AKI or chronic kidney disease, then a VQ scan is preferred rather than a CTPA, because in these patients you don't want to induce any contrast nephropathy, so that's why a VQ scan is preferred rather than a CTPA. Now, this is an example of sinus tachycardia, which occurs quite classically in an ECG of a patient with PE, and this is an example of the S1Q3T3 sign, which again is very classic of a PE. So you've got deep S waves in lead 1, so that's the S1, and then the Q3 is when you've got very deep Q waves in lead 3, and then T3 describes inverted T waves in lead 3. So the two classic features of a PE on an ECG involves sinus tachycardia, as we saw previously, and the S1Q3T3 sign, which is this particular ECG finding. Okay. So now we're going to be looking at the management of a PE. So the management of a PE, first line, is using a Pixaban or Rivaroxaban. Now, if a Pixaban or Rivaroxaban are both unsuitable, then we would offer the patient low molecular weight heparin and either dabigatran or edoxaban, or we could offer the patient low molecular weight heparin and warfarin. Now, if the patient has a severe renal impairment like an AKI, we would offer the patient instead warfarin and low molecular weight heparin, or unfractionated heparin, or low molecular weight heparin on its own. Now, patients who are suffering from PE due to an underlying antiphospholipid syndrome, we would offer them warfarin and low molecular weight heparin. Cancer patients will receive apixaban or rivaroxaban. Now, anticoagulation therapy, as you can see, is quite key for PE. So patients who have a provoked PE, so this is when the PE is due to surgery, trauma or immobility, need to continue anticoagulation therapy for 3 months. Patients who are suffering from a non-provoked PE, so the PE is not due to surgery, it's not due to trauma or not due to any immobility, it's not due to any attributable cause, these patients need to continue anticoagulation for 6 months. Now, if a patient presents with PE and has signs of hypotension, then the first line management is to offer thrombolysis. Now, if the patient has recurrent emboli despite receiving anticoagulation, then we would consider giving these patients an inferior vena cava filter. Now, finally, we're going to look at pneumonia. So there are different types of pneumonias, and pneumonia can lead to pleuritic chest pain. So there's a community-acquired pneumonia, hospital-acquired, or a ventilator-associated pneumonia, aspiration pneumonia, and atypical pneumonias. So you do need to know the underlying microorganisms that lead to these specific infections. Now, atypical pneumonias are quite interesting. So Legionella pneumophila is associated with water-based sources. So in the SBA, it might be that a patient's gone on holiday and they've been swimming in the local swimming pool and they've then gone on to develop a pneumonia. And even more importantly, a pneumocystis jirovecii infection is typically and classically found in immunocompromised patients. So patients who've got a HIV infection will suffer from pneumonia due to a pneumocystis jirovecii infection. Mycoplasma pneumonia is a very interesting form of pneumonia. So mycoplasma pneumonia is associated with other conditions like erythema multiforme, and we'll discuss that in more detail now. So the classic signs of pneumonia involves pleuritic chest pain, fever, productive cough, dullness to percussion, and coarse crackles. Now, you need to know some of the classic features which are attributed to certain organisms that lead to pneumonia. So Streptococcus pneumonia will present with fever and herpes ovalis. Legionella pneumonia is associated with hyponatremia and lymphopenia. And like I mentioned previously, a mycoplasma pneumonia is found in patients presenting with a dry cough, erythema multiforme, and autoimmune hemolytic anemias. Now, something which I forgot to mention previously is that an aspiration pneumonia classically presents with consolidation in the right lower base and also bronchial breathing in the right base, because the right inferior bronchi is involved in aspiration pneumonias. So I mentioned previously that pneumocystis jirovecii is found in patients suffering with HIV. The management of pneumocystis jirovecii isn't quite interesting. It's managed with cotrimoxazole, or it's managed with pentamidine. So these patients suffering from a pneumocystis jirovecii infection will, like I say, be suffering from HIV. They'll also be suffering with several days or several weeks of increasing shortness of breath. They will present with a dry cough and oxygen desaturation with exercise. So let's say they had 98% saturation of oxygen at rest, and during exercise this has now fallen to, let's say for instance, 86%. So that's an example of oxygen desaturation with exercise, and that's something that classically presents in pneumocystis jirovecii and comes up time and time again for SBAs, so just keep that in mind. Now, looking at the tests, so we need to perform a full blood count, CRP, and using these as part of our bedside investigations. We need to perform LFTs because the LFTs are deranged in Legionella pneumophila. We do an ECG to exclude for cardiac causes of chest pain. We need to perform a blood culture and sputum culture. A chest X-ray is your gold standard in pneumonia. We can follow it up with a CT scan of the chest. Now for the atypical pneumonias, so particularly for the Legionella pneumonia and the Mycoplasma pneumonia, we need to perform urinary Legionella antigens, we need to investigate for cold agglutinins, Mycoplasma chlamydia and pneumococcal antigens. Now the management of pneumonia is underlined by the Curve 65 score. So the Curve 65 score is something that I would recommend that you learn for your exams because it's a very easy mnemonic and it is important in helping to triage patients. So if your Curve 65 score is less than 1, these patients are managed in the community. So they need to receive 5 days of amoxicillin, but if they're allergic to penicillin, they can receive clarithromycin or doxycycline. Now, if the Curve 65 score is equal to 2, these patients need to be in hospital with a 10-day treatment plan of amoxicillin, and simply again, if they're allergic to penicillin, then offer clarithromycin. If your Curve score is equal to or greater than 3, a 10-day treatment plan involving coamoxiclav or ceftriaxone or tazothin and clarithromycin is needed, and these patients are managed in ITU. Now, Legionella pneumophilia or Mycoplasma pneumonia are treated with doxycycline, and like I mentioned previously, pneumocystis jirovecii is managed with cotrimoxazole or pentamidine. So thank you for staying with me. I appreciate today has been a very long video. I just want to say if you enjoyed my video today, please give me a thumbs up. Please subscribe to my YouTube channel. Please comment in the section below and also share this video with your friends. Thank you once again for watching this video, and I wish you all the best with your exams.